forgot to record my lesson. I'm so sorry. So we have the blood coagulation factors. We have the serum lipids. The serum lipids, they are the lipid profile measures serum cholesterol, triglyceride, and lipoproteins level. That's the LD, the lower density lipoprotein and the high density lipoprotein. Those are the cholesterol stuff. Now, highly sensitive C-reactive protein is also part of the labs they will get. All that you will see it done on the CBC. We have the potassium you want to know. Now I put a note here in hypokalemia, the EKG shows flattening inversion of the T wave, the appearance of a U wave, and a ST depression. So I had explained the EKG rhythm, and on the EKG rhythm, if there's flattening and inversion of the T wave, there will also be an appearance of U wave. So anytime there's appearance of U wave, you want to be careful because U wave will indicate hypokalemia, low calcium. That means the patient potassium is low. Is it hyper or hypo? Yeah, it's hypokalemia. Low potassium will cause a U wave to be depressed. It will cause the appearance of U wave. On a normal EKG reading, we don't have a U wave. But when you see a U wave, suspect low potassium or hypercalcemia, high calcium, or hyperthyroidism. Those are the three. Low potassium for U wave appearance on an EKG strip, high calcium, or hyperthyroidism. But on the NCLEX, if you have all these three options presented to you, that a patient comes with all these things and they are all in the answer options, you want to go in for the potassium because potassium works directly on the heart muscle. So hyperkalemia on the EKG strip will also show a tall T wave, tall peak T wave. So this is opposite, hyper and hypokalemia. In the hypokalemia, the low potassium, the T wave will be inverted. It comes down. So instead of being a V like this, the T wave comes down like this. But in the hyper, if the potassium is too much, that means it stays normal, but it's being pushed up higher. So the T wave is peaked. It goes up higher than it should. And the QRS, which is the ventricular activities, gets wider. And there's a prolonged PR interval or flat P wave. So that's working on the atrium as well. We have sodium, calcium. I'm not going to tackle that. All you need to know these ones is to know their normal levels. So these are things they use to identify heart problems. That's why I have them captured. We have phosphorus. We use phosphorus to also measure the function of the heart. It interprets the calcium levels because the kidneys retain or excrete one electrolyte in an inverse relationship to the other. So the phosphorus level is also part of measuring the function of the heart because we know that when the blood goes out of the heart, it goes straight to the kidney to be filtered out and then we get urine from it. But if it starts backing up, the phosphorus level that doesn't work to absorb the calcium levels, and this affect the kidney function. So the next one is myocardium, magnesium, I'm sorry. Magnesium is, so low magnesium will cause ventricular tachycardia and ventricular fibrillation, VFib. So low magnesium can also cause the heart. So it's part of the labs that has been captured. Now, I said you should note anytime I put the marking in highlighted form is something you need to take note of. That means NCLEX actually has so much interest on that one. Anyone I put a highlight on it in the notes when you are reading, take notice of that and understand it. NCLEX has a spot on it. They will twist that particular one and bring a question on it. Electrolyte and mineral imbalance can cause cardiac electrical contract instability that can result in life-threatening dysrhythmia. So electrolyte, that is magnesium, potassium, sodium, calcium, and what? Those ones that I mentioned, lipids, proteins, the LDL, low cholesterol, and all those things. It can cause electrical instability. It can make the electrical activity of the heart unstable. That's the sinus, the SA node, and the AV node activities of the Purkinje fibers. Those ones, their activities can become unstable, and this can cause a life-threatening injury. So we also want to know the BUN, blood urea nitrogen. The blood urea nitrogen level is elevated in the heart. Disorder is such as heart failure, cardiogenic shock that reduce renal circulation. So anything that affects renal circulation, when we talk about, we had mentioned, which one did we mention about the kidney as well? That was the phosphorus level. So this is where they give you the phosphate binders like Remvela. So those ones are kidneys. They relate more to the kidney. When you see phosphorus, you see blood urea nitrogen, you see creatinine. You want to be careful. Those ones go more with the kidneys, but they also get impacted when a patient is injured or when the heart is troubled, because that means the flow of blood is not consistent to the kidney. So there's a backup and there's a problem with them too. So all those labs will also count. So the B-type natriuretic peptide is released in response to atrial and ventricular stretch. If your heart is stretched too much, there's too much pushing and pumping, this one gets stretched out, and this can also be seen in heart failure situations. So when you do all the labs, when you draw a patient blood in the tube, they go to run it, and all these things shows up. We have the CBC and the CMP plus the troponin that goes in a separate tube. But the CBC and the CMP, especially which one did I mention here? The complete blood count. It has all these things in them under one tube. You get all these things with their values on them. I have a picture of that, but I wouldn't show that right now because it's not what we need. Now, we also do X-ray to identify heart problems. So all these ones I've been talking about are blood work you will do for the patient to identify a heart problem. So when you do a lab and they tell you one of these has a problem, they're suspecting your heart, they do a further study to know why. They go to X-ray. So you now have an X-ray to do. And we all know what X-ray is to give a picture reading of your heart. So they are able to interpret it based on what they see on the EKG or on the X-ray picture or on the X-ray film. They used to print them before. Right now it's just digital form. I know some places still use the printing form, but right now majority of facilities have the X-ray as digital pictures. You log into the patient chart, you're able to view everything. Now, I'm not going to talk about the interventions, but we know that EKG, if a patient has to go to EKG, NCLEX, what they want you to know is for every X-ray procedure the patient is going to go, every every CT scan procedure the patient will do, anything that use radiations and it's a procedure a patient is going to go, you're going to have a preparative process, and that will involve taking off any metal, any dentures, anything that is foreign in the person's body because it's radiation. So X-ray is radiation, CAT scan is radiation, MRI, you want to take all those things out of the patient. Apart from ultrasound, that is a non-invasive procedure. Now we have the Holter monitoring. The Holter monitoring is a non-invasive test. So they put like some pads or leads on the patient, and then they have a little box. It's just a machine. So it's reading, it's just a small thing like this, and they have the lines, they connect it to the patient heart. So the patient is busy moving all day. The patient have the Holter monitor that is recording the thing and is sending the information to the provider's office. So the provider is able to log in and see what is going on with the patient without you being present with me. So in most cases, for patients with those cardiac problems, they put them in their rooms and they put the Holter monitor, and the nurses are sitting at the nurses station and they are able to understand what is going on with the patient heart. So there is a constant, continuous monitoring, non-invasive process. That's Holter monitor, and it's continuously over a period of 24 hours. So some of these procedures is non-invasive. So because it's non-invasive, You are not worried about taking off earrings. It doesn't distract your activities of daily living. You are just moving and doing your things unless you're sick. So try to be careful. NCLEX will want you to be able to differentiate between activities that will affect what you have or how your care is going. So if it's X-ray, if it's a radiation procedure, you have to prepare the patient's mind. That's where education comes. So make up your mind while you are studying any NCLEX book that your job on this NCLEX is to know how to educate a patient. On every question, NCLEX is going to give it to you because they are tasking your ability to tell the patient an information. You are not allowed to ignore patient questions. You are not allowed to jump over them. You are expected to be a professional. I was discussing professionalism in one of my videos. You are expected to be a professional, and a professional should have a body of knowledge to be able to teach. So your role in most cardiovascular system is your nursing interventions, which you will be teaching at all times. You identify a problem, you have to teach. So make up your mind that this NCLEX you are going to write, you are going to take notice of teaching information of topics that you'll be able to tell the patient, because the patient will ask you questions. And that's what NCLEX use. So for instance, I have a patient that came to us, that came to the emergency room the other day, and he's complaining of pain. He's complaining of abdominal pain, and he wants to know because he had a history of gallstones, but he doesn't know where that pain was coming from. He don't remember. Now the question is, he wants to know which part of my body is my gallbladder located? That's an NCLEX question. What will you tell this patient? Simone, I know you just logged in. I'm giving a scenario of where a patient came in complaining of stomach pain to the left upper side, saying that I had a history of gallstones several years ago. I don't remember which part of my stomach that pain was, and they told me it was gallstones. And now the patient is asking to know which part of my body is my gallbladder located. Are we hearing me?
Yes.
Yeah, it's really hard if I can't see you guys. I feel like I'm just talking to the air. It's hard for me. I want to know if people are seeing, if people are understanding what I'm saying, or they are getting me right. It's really a little challenging for me. So I feel like I'm just talking to myself. So the patient wanted to know if they can tell her I can tell him which part of her body her gallbladder is located. So that is another reason why I show you the images, for you to look at it and know where it is, because that's what NCLEX wants you to know. So when you sit on that exams, the patient comes to you with a question, the patient wants, they know you know everything. That's why you are wearing that uniform. So he wanted to know where his gallbladder is located. You can't say it's located on your chest. If you say it's located on the right, do you really think it's true? And you can't tell the patient wrong information. So you need to know how to teach a patient, because that's what NCLEX wants you to know before you can pass. And if you don't know the interventions you are supposed to tell a patient, or you are supposed to intervene for a patient problem, how then do you teach a patient? So this is one thing I want to tell you. When you are studying for these exams, don't just read a topic and come back to read it tomorrow. Make sure you are reading and understanding specific information that if a patient comes to ask you, you'll be able to tell them the correct information, because NCLEX will want you to teach patients on the computer. So the 4 patients NCLEX gives you, they want you to be able to teach them. Now, the interventions for the Holter monitor, I'm not going to talk about it. You just need to instruct patient. So anywhere that say instruct patient is teaching. You are instructing, you are teaching. That's the nursing function. They don't want you to go thinking about how to only give medication. They want you to be able to tell them what that medication is and what it's supposed to do in their bodies. So you instruct them normal daily activities. They will resume their normal daily activities. They will not be worried, and they'll be monitoring every day going. They'll know. The only thing you'll be worried about is to instruct them using wired monitor to avoid tap bars. They need to, because of the Holter monitor that they have on them, it uses wires. So they need to avoid tap baths, showers, or swimming. Anything that will immerse your whole body inside that water, they need to avoid that. But that doesn't mean they cannot bath, but they can't have a tap bath. You can't fill up the tap and go throw yourself in there. So they need to avoid all that. And because they will interfere with electrocardiographic recording devices. So we all know you cannot go into the shower with your phone. So anything that is electronic, you cannot mess with it with water. Now we have the electrocardiography. This is also non-invasive. So this one, you can have your earrings on. You can have your necklace on. It's just ultrasound of the heart. So electrocardiography is ultrasound of the heart. They use transmission gel, they put it on your heart, and then they just roam in to find the heart structures. They see all the valves and everything that is in your heart. So electrocardiography is non-invasive. We have the transesophageal echocardiography, and this one may be performed in which the echocardiogram is done through the esophagus to view the posterior structures of the heart. This is an invasive exam. So in this one, they put a tube down to your, your esophagus. It's like when they do the, endoscopy. They put the tube down through your esophagus, and then the doctor is able to view it. They use an endoscope. So when they use the endoscopic procedure, they use a microscope to be able to view the internal structures. They push the wire, the soft wire down your esophagus to your heart, and they are able to turn on the light. So the light will capture the space around your heart, and they are able to see, the doctor is able to see with his own eye. It's nobody's eye. It's not a computer interpreted. It's the doctor who sees it, and the doctor needs to know normal structures to be able to figure out. Now we have exercise. This is the stress testing. This is when you tell a patient to go and do running on a machine to see how much they can endure the stress of their heart. So you have the patient run and you get their vital signs to see how much their heart is racing. You know, when you do exercise, it causes an increase in your heart rate. So this one, the procedure, you have to ensure that an informed consent is obtained at all times. We don't get the consent, but we can reinforce education on consent. LPNs can reinforce education. So you need to know the ideal before you can reinforce. So if the doctor told the patient the procedure for stress test was for you to go and sit on top of a machine, the machine is moving you back and forth, and the patient got confused, and you walk in as the nurse, you walk in as the LPN taking care of this patient. The question is, the patient asks you, did the doctor just tell me I'm going to sit on the computer and the machine will be bouncing me up and down? It tells you the patient don't understand. If you don't know what the stress test is, how do you teach this patient? How do you correct this patient misunderstanding? Because the patient is not going to sit on the machine to have it move up and down. The patient is going to have to do some kind of running activity to have the heart move, and then they check the heart rate to see how the heart is racing. So these are things that you need to know to be able to educate the patient. That's why I'm spending time on them. So when you go to write the NCLEX, you are not just going to go because you know only this content, but you know how to interpret this content in telling a patient information. So when it's not enough to just know it yourself, it's enough for you to know and go and teach. Teaching is a nursing function. Advocacy is a nursing function. So you make sure the doctors don't do wrong procedures on the patient. So if the patient problem is math, the doctor don't go and, if the problem is gum, or the problem is the patient toenail, the doctor don't go and extract the patient tooth. That means you, the nurse, have not played a good role. I'm going to jump this one. We have the MRI, the magnetic resonance imaging. Magnetic alone will tell you they use waves, but it's non-invasive. It doesn't go into the patient, but they use magnetic waves. So because of the magnetic fields around it, we know what a magnet is. We know how it can attach to stuff. So you don't want the patient having earrings that is metal. It will go and it will cause problem. So it uses magnetic waves, but it's non-invasive. X-ray is non-invasive. CT scan is non-invasive. Ultrasound is non-invasive. Most of these procedures are non-invasive. Apart from the cardiac catheterization, which I'm coming to talk about, they have to put a catheter through your heart to be able to get a diagnosis. So this one, it interferes with your coronary circulation system. So that one is an invasive procedure. All I've been discussing along is non-invasive. The only invasive one I had talked about would be the needle that they will poke you and get the blood for the cardiac troponin and the complete blood count. All the scan stuff is non-invasive. Now we have the cardiac catheterization. This is an invasive test that involves inserting a catheter into the heart and surrounding vessels. And it obtains information about the structure and performance of the heart chambers and involves valves and the coronary circulation. So they put a catheter through the heart, and this one will produce an information. Now you want to assess the patient for informed consent. Mind you, everything that is a procedure that you know is consent. You just don't come and pick me because I'm a patient and go and put me down to x-ray without telling me I'm coming to take an x-ray. Most of the simple procedures will be a verbal consent. Okay, so we want to get an x-ray for you today to be able to determine what's going on in your heart. That is informed consent. That's a consent. It's a verbal one. So remember, NCLEX will want to know if you know the types of consent. So this one is just going to be a verbal consent. We want to take blood to go and check your heart muscle to see with your chest pain. That's an education you are doing in the first place. You are educating the patient what the procedure is and why you are doing it. But you are getting a consent because you get a patient response. It's okay, you can take my blood. It's okay, you can send me to x-ray. Those are verbal consent. Besides that, procedures that are invasive, you want to have them signed. So this is cardiac catheterization. You're putting a tube inside the patient chart. It's invasive. You need a written consent. The patient has to sign that I accept to have you put it inside of me. You are invading into their body and they have to agree to you to do that. So in that procedure, you want to assess if the patient has any allergies to seafood. So we know that seafood, if they tell you in NCLEX, they won't mention seafood. Take note. NCLEX is not going to mention to you that seafood, patient is allergic to seafood. If they mention to you that way, you are lucky. That means they're just taking you straight to content. They are going to give you the kind of seafood they want to talk about. They tell you, the patient says, I am allergic to shrimp. So you need to know shrimp is seafood. You need to know shrimp has a form of iodine in it. Then, if they're given a contrast for that procedure, the patient is not supposed to get it. But if you don't know shrimp is a seafood, then you're in trouble. Or they tell you shellfish. So on the NCLEX, if you don't know shellfish, it's a problem. You are going to prepare this patient for this procedure, and the patient go and they inject the dye before they start the procedure. The patient cold. The patient will start having shortness of breath and cannot make it for the procedure. It bounces back to you. That brings me to legal nursing. So you want to be mindful of some of these things. Invasive procedures that use contrast. You want to take consent and you want to have the patient allergies. So this also brings me to telling you that for every patient you take care of on the NCLEX, you need to know if they're allergic to any food or their medication. So their allergies are very crucial in the kind of care you give to them. And you want to withhold food, anything that is invasive towards the chest, the liver, the GI system. You want to think of vomiting. So you want to withhold food. They have to maintain NPO for a certain time. So at least you have to give, the NCLEX will give you options. So you have to give yourself timing for your stomach to empty out. So it cannot just be 1 hour, because 1 hour, it won't empty out everything. So you have to give yourself at least 4 hours or 6 to 8 hours. And 4 hours is usually liquid they expect. So you want to prevent vomiting and aspiration. Now, I told you if you see anything in yellow, you want to note that a client that is taking metformin should should not undergo a procedure requiring administration of iodine. That's what I wanted to say. If a client taking metformin is scheduled to undergo a procedure that require the administration of iodine, the metformin is withheld for 24 hours period to the procedure because of the risk of lactic acidosis. The medication is not resumed until prescribed by the healthcare provider, usually 48 hours after the procedure or after renal function studies are done and the results are evaluated. So for a patient going for a cardiac procedure or a patient going for a procedure that is going to take iodine, that they're going to give the patient iodine dye, a contrast. That's contrast. Another name for the iodine dye is a contrast. If the patient is taking metformin, now this goes to Simone. I see she logged out. I would love to say that to her. For those who have been on the floors, those who have worked in the hospitals, you see patients going for CAT scan and they are diabetics, they've been taking metformin and they keep going for CAT scan because they come in with abdominal distension and other problems, and they are going for CAT scan and they have an order of standing metformin they take daily. You are not supposed to take metformin with anklets. That is the floor jab. Leave it. We have standard practices by the facilities. Anklets is not limiting you to one facility. You can't use it. The book says if the patient take metformin and is going to get a procedure that will use a dye, you have to stop the metformin 24 hours. So the patient walk up to you today and say, oh, I took my metformin today because I'm a diabetic, but I have been scheduled for cardiac stuff that the doctor want to put something in my heart to do testing. The patient is telling you what procedure she's coming to do. And you, the nurse, need to know that if the patient took the metformin today, then the patient shouldn't get that procedure. You have to report it because patients will start by telling nurses their information before they get to the doctor. So if you don't stop it, you end up giving this patient lactic acidosis, which is another complication to manage. And when it comes to legal terms, you get hooked up. We'll talk about legal nursing later. Now I'm going to jump. These are percutaneous transluminary coronary angioplasty. These are all invasive procedures. So like I discussed, for invasive procedures, you need consent. Take note of that. An invasive consent with the heart problems, you want to have the patient maintain NPO. These are general management terms you need to know. You need to educate the patient not to take metformin with those that go with dye. Now, I have another note for you, coronary artery stents. These are stents that they go into the patient's coronary arteries. We have the arteries that supply the whole heart. So they place stents on them if any of the valves are not working well. So if the mitral valve or the tricuspid valve is not working well, they go inside and they pull it out. They put an artificial valve inside and it's working for the patient. So we have thrombosis is a major concern following the procedure. The patient is placed on antiplatelets such as clopidogrel and aspirin for several months following the procedure. Length of time of antiplatelet is determined by the type of the stent and the metal. So the doctor will determine how long the patient is going to take the medication for, or the patient is going to take the blood thinner for. So because they have invaded inside the heart and they place a stent, they are worried that there may be a blood clot in there, because if a foreign object has been placed inside your heart, then they don't know what can happen. They want to be on the safer side. They put you on blood thinners to make sure your blood is thin enough to flow through it until your body adjusts to it. Now, coronary bypass graft. This one is the occluded coronary arteries are bypassed with the client's own venous or atrial blood vessels. They just use a graft. They pull the arteries and they join them together for the patient. So they just go into your heart and they think like this part of it is diseased. So we cut that out and we pull this and we graft it. They join it together. That's what that procedure is. I don't want to talk about the surgical component, but I want to talk about heart transplantation. And we have a donor heart from an individual who is so these ones are topics that NCLEX actually like, especially in our recent days. People get a lot of heart transplants, liver transplant, eye transplant, a lot of organ transplants. So if the patient is getting a heart transplant, this is straightforward. You understand that the patient is getting a foreign heart. So they have to check the compatibility, the body weight of the patient and the compatibility of the particular heart they are getting. So if I am a 5-year-old and you are a 50-year-old male, how do you expect my heart to be able to supply your body with blood? My heart cannot function for you. So they do studies before they try to assume the surgical procedure. Now, I jumped this part. Atrial fibrillation. I think I spoke about these ones. Those topics. Gertrude, are you with me? Hello?
I'm here.
Okay. So the ventricular fibrillation, AFib, and all those things are EKG rhythms, and I have a whole topic on that. So I'm going to jump that one. I'm definitely going to tackle it later with you. I had done that last week, but I'm going to jump the AFib and all those things. Okay, so don't worry that I'm jumping them. I'll give you the notes to read, but I have all of that captured. I take that as a step to just teach it very well so that you pick it one time and you don't go back to them. So cardioversion is a synchronized shock to convert an, okay, I think these are treatments, right? Okay, I don't know about that. Okay, so I'm going to talk of the interventions. I'm just going to talk of only the interventions for these problems. I'm not going to talk more into that. I'm going to talk about their interventions. So for the heart transplant, we have the cardiac dysrhythmias. So cardiac dysrhythmias, we have the normal sinus rhythm, sinus bradycardia. We know sinus rhythm should have a heartbeat of 60 to 100. That was what I talked about. That's part of the EKG strips. Now the intervention is an attempt to determine the cause of sinus bradycardia. So when a patient has a low heartbeat, the provider or you, the nurse, you all want to assess further to know what is causing it. And the treatment for you to do is to administer oxygen as prescribed for the symptomatic client. So a client is exhibiting bradycardia, the heart rate is low, so you want to give them oxygen. You administer atropine sulfate. So I have a candidate that went in for the exam. The person told me he got a question like this: how to manage bradycardia. They gave him an EKG strip, which I had done before. They gave the person an EKG strip, and the person was asked to identify what treatment was. So they put in the medications there. You need to know that atropine is the one that will kickstart the heart to increase the heartbeats from the abnormal state or from the lower one to the normal side. So we have atropine for the treatment of sinus bradycardia. NCLEX want you to be able to know that. Now we have the sinus tachycardia. The heartbeat is above 100. So if it's above 100, what do? Your aim is to decrease it. So you identify what is causing the tachycardia, what is causing the high heart rate, then decreasing the heart rate to normal by treating the underlying cause. So if the patient just finished running, you want to have that patient take a rest to be able to decrease the heart rate. Now, AFib, if the patient is having ventricular arterial fibrillation, the patient has AFib, what you want to do is there'll be multiple rapid impulses from many focal depolarize in the atria in a totally disorganized manner at a rate of 350 to 600 times per minute. So the atria will start quivering, which can lead to the formation of thrombi. That's the thrombus formation and all those things. And usually no definitive P wave on there will be observed. Okay, so I'm going to go to the interventions for this. So leave the AFib alone. I'm going to go into AFib and I'm going to show you a rhythm of how an AFib should be seen and how you'll be able to identify AFib. So, so you administer anticoagulants. Remember, they talked about depolarization and they spoke about the heart quivering. So you want to administer anticoagulant to help with the risk of emboli, thrombus formation. And then you administer cardiac medications that are prescribed for ventricular rhythms. And then you prepare the client for cardioversion. So if the patient is having atrial fibrillation, if you look on the EKG strip and it's AFib, you want to prepare the patient for cardioversion. So when you prepare the patient for cardioversion, you will be on the right track. So the NCLEX will give you a rhythm you will see that among all this rhythm is AFib you are going to choose. So among all these patients, the patient is sinus rhythm. So if it's sinus rhythm, you are not worried about it. It's normal. They give you sinus brady, and then they give you the sinus tachycardia, and they add atrial fibrillation rhythm. They are going to give you the EKG rhythms. They are not going to tell you what it is. And they want you to identify this patient and what treatment you will give. So if you see the rhythm and you are able to identify that this one is atrial fibrillation, this one is sinus rhythm, this one is sinus bradycardia, sinus tachycardia. And the answer options are not talking about giving atropine for a sinus brady patient, and they are talking about they want you to be able to identify that the heart is quivering, and then there may be a risk for thrombi formation. Then you want to choose that administering anticoagulant and preparing the patient for cardioversion is the correct answer for AFib. So you want to note that. Simone, I'm talking about, I know you had come off. I'm now talking about the interventions for the EKG strips. If you remember the last time I told you, I have the interventions captured in another note. So these are the interventions for the EKG strips. So since you have information of what they are, I have the interventions here. I'm only talking about the interventions. I'm not talking about the readings because I have a separate whole lesson on that. So for the AFib, you want to take note. The intervention for that one will be to give the patient anticoagulant because of the risk of formation of thromboembolus. And then cardioversion is prescribed. So AFib, we give cardioversion. Sinus bradycardia, you want to give the patient atropine. I know somebody who went for the test and told me they had wanted the person to identify which EKG, which treatment will this strip require, this EKG rhythm need. And the rhythm was bradycardia. This rhythm was sinus brady. So if you don't know that the correct treatment for sinus bradycardia is atropine to help make the heartbeat come faster, you will miss that answer. So that was a straightforward question. Those are the things I wanted to be able to see and identify. So like I explained before.
Okay, so you were saying for atrial fibrillation, if it's the patient is tachy, you give anticoagulants, and if the patient is brady, you give atropine.
Yes. No. Sinus brady is atropine. Sinus bradycardia is atropine. And if the patient is sinus brady is atropine, I repeat again, I'm sorry. Yeah, sinus brady is atropine to kickstart the heart. Now, AFib is anticoagulant and cardioversion. You prepare the patient for cardioversion. The anticoagulant is as a result that in AFib, the atrium is quivering. It's not able to move out the blood enough. It's quivering, it's that kind of shaky. So because the blood is getting stuck in there, there's a risk for thrombus to form or emboli. There's a risk for embolism. So because of the risk of embolism, you give anticoagulant to help dissolve every blood clot. So take note of that. Now we have premature ventricular contractions. We have
a person who is suffering from atrial fibrillation, are they at risk of pulmonary embolism?
Yes. they are at risk for embolism.
Okay.
Okay. Remember, the pulmonary embolism, it goes through the pulmonary vein and pulmonary artery to the liver. If you remember the connection I showed you, the pulmonary vein to the lungs, and then back through the pulmonary artery. So because the pulmonary circulation is involved in there from heart to lungs, they are at risk for pulmonary embolism. So anticoagulant will help smoothing the flow of blood in and out. So if you have that in mind and you start seeing atrial fibrillation, you know the atrium will move the blood and then it goes to the lung and the pulmonary is involved. You'll be able to pick the answer: anticoagulant for emboli and prepare the patient for cardioversion. Those are the things I want you to take note of. Okay.
Okay.
Now, the intervention for premature ventricular contractions is to identify the cause and treat on a basis. Now, I didn't say this. For sinus tachycardia, you need to identify the cause and you treat it. If the patient is having, I don't know if I captured supraventricular tachy, but if it's supraventricular tachycardia, you want to give adenosine. You want to give the patient adenosine to abort the shaky, like the fibrillation or the fast movement of the heart. You want to slow it down. So you give adenosine to push it. Okay? That's supraventricular tachy, SVT, adenosine.
Okay.
Yeah. Now, I was talking about premature ventricular. So for sinus tachy, the best solution is to identify what is causing it, and then you take away the causes. And when you take away the cause, the patient comes back to normal. Now, I put a note here again in a yellow thing that for the client who is experiencing premature ventricular contractions, is that what it is? Yes, premature ventricular contractions. We want to notify the care provider or the cardiologist that the client complaint of chest pain. In case the client you are taking care of has been diagnosed as premature ventricular contractions, and the client complained to you that have chest pain, then you quickly want to notify the provider, okay? And they will also get, you also get an order for EKG. And on the EKG, you see that let me just read it. If the PVCs increase in frequency, there are multifocal points occur on the T wave, R on T. Or, so you see the R wave, you see the QRS. So the distance from the R complex to the T wave, there's a multifocal point on it. And this runs as ventricular tachycardia. So you see that the distance from there will be shortened and it start getting closer to each other instead of giving each other space, QRS and T. So instead of the T going a little further, the T starts coming shorter because the QRS is putting pressure on the T. Now, ventricular tachycardia, we have the stable client with VT. So if the patient is stable and is having VTAC with pulse and no signs of symptoms of decreased cardiac output, you want to administer oxygen. You want to administer antidysrhythmic medications as prescribed. So if a patient is stable and it's just that you are having VT, ventricular tachycardia, the best thing the nurse want to do is to give the patient oxygen. So if NCLEX give you the reading, they give you the reading and you see it's VT, ventricular tachycardia, what you do is, that's what I said before, you identify the causes and you try to tackle it. So you see this is VT, the patient it's only the heart rate that is high. Patient doesn't have chest pain, patient don't add any complaint, but you see the heart rate is not normal. Then you want to just give oxygen and see. So you give the oxygen and prescribe antidysrhythmics, and that will help the patient. For those that are unstable, they have a pulse and signs and symptoms of decreased cardiac output. So you can see that they have a pulse, but maybe the heart rate is low. No, this is tachy. The heart rate is high, but you can feel that their heart is not working proper. The patient complains of chest pain. There are other complaints besides just the V tachy that you see on the diagnosis. So if they have other complaints, you still give them oxygen and the antidysrhythmics as prescribed. You prepare them for synchronized cardioversion if the client is not stable. So the patient come in and you see them still sweating, and their heart rate is just high. And they tell you, my heart is just beating, it's just kicking. You want to prepare them for synchronized cardioversion. So the healthcare provider may attempt cough cardiopulmonary resuscitation by asking the client to cough hard every 1 to 3 seconds. And then pulseless client, for those who don't have a pulse, that's ventricular tachycardia, you defibrillate and you start CPR. So anytime you hear CPR, that means there is no pulse. So NCLEX, they like those things. When it comes to cardiovascular system, I tell you, I don't want to waste my time explaining this. I want you guys to go into it. Cardiovascular system, there's no way you go through NCLEX without going over it, because right now we have so many stents. People have heart stents. People have a lot of heart surgeries. People have a lot of cardiovascular problems to the extent that they are so interested in it. So you cannot go through NCLEX without getting it. That's why EKG reading is a whole set on its own, because human beings have one heart, and that heart will pump all years of your life. It doesn't stop. So when it starts getting diseased, that's why we have a lot of cardiovascular problems out there, because it's only one heart supplying the whole body, and this heart never stops beating. The moment you stop, you are dead. So because the heart works all year long of your life, we have a lot of heart problems out there. NCLEX is much particular about cardiovascular system disorders. So just take note of that. I don't know if we should take a break and come back. Maybe I've been talking too much, but let me just finish the VTAC. So ventricular fibrillation, you want to initiate CPR and defibrillate the patient. That's VFib. We always know this. So VFib, the first thing is CPR, okay? So when the ventricles start quivering, start having a problem, the first thing is to try to abort that and have the ventricles work faster. That means your whole body will start getting enough blood. So you want to give CPR right away to increase. We have the vagal maneuver, which is stimulation of the cardiac conduction system and used to terminate supraventricular tachycardia. So this was the one I was telling you about, Simone. This is the one that you tell the patient to blow. You tell them to blow. So they kind of put pressure on their chest and they blow up and a lot of air fills in. You want to try to have them manipulate their own heart to work. So you pump in, you push in, you do like, you teach them. It's like a form of breathing exercise that they take it deep and then they open up and blow. So when they blow, it's supposed to help kickstart the heart to work normal. If that one doesn't work, that's when you give the adenosine. Okay, so if that one doesn't work for supraventricular tachycardia, they give adenosine, and they can also prepare the patient for cardioversion, which is synchronized.
The blowing is considered an intervention, because you said you allow them to do it to kind of manipulate their own heart to work. So would you consider that an intervention?
It's not necessarily, it's an intervention, but it's not something you will base more on it. You just have them do it for 1 or 2 times. And if it doesn't reverse, you cannot waste time with that, because the heart is constantly moving up and down. I had a patient 2 days ago that had that. I forgot to get the reading. I wanted to get the reading and cross out the patient information and come and show it to you. But it was so quick that I had to rush over it. So I couldn't get the reading on time. Before I remembered to get the reading, I had sent the patient to ICU. So I didn't capture the reading. I wanted to show you people, because the patient was normal. All of a sudden, the patient sees me and she says she gets nervous, because anytime she sees healthcare workers, she gets nervous. So she see me, her heart rate jumped to 184. or 88, and it's not stopping. She feel like her heart is racing. So in that case, I asked her to take a deep breath. So she take a deep breath, it's not working. I asked her to blow. So she should do like you are blowing through a horn, so that you have, when you do that, it helps you to relax. It's just like relaxation therapy to see if the heart will relax. But if that doesn't work, it's not an intervention. It's not like a medical intervention would do. It's just like educating the patient to do deep breaths to see if that helps. If that doesn't help, then you have to look for other interventions. So the first thing I did was to assess the patient. When the patient told me my heart is racing, first thing I checked the heart rate. I checked the vital signs, and I realized that the heart rate was 180 something. I was just taking the patient out of the floor at that moment. Escort was ready, everybody was ready to move the patient, but this was a newly identified symptom, and that's what NCLEX will tell you. So just when I was about to move with my patient, this is what she tells me. My heart, I just feel like my heart started racing right now. And then that's something you should be concerned about. So I just checked the vitals, and I realized the problem. I said, do you still feel it? She said, yes. I said, okay, blow. She did it for 1 minute, 2 minutes, 2 times. Okay, 1 time, 2 times. There was no change in the vitals. I repeated the vital, there's no change. So you notify provider, and that you have to prepare for synchronized cardioversion. If they want you to talk, they want to talk about medication, you give adenosine to abort the tachycardia. Okay. So take note of defibrillation. I think I mentioned this one before. So when you are going to defibrillate, you are going to charge to 120 to 200 joules or 360 joules monophasic. So we have the biphasic and monophasic for one counter shock for the defibrillator. And the CPR is resumed immediately and continued for 5 cycles or 2 minutes. So CPR is continued for 5 cycles for about 2 minutes before another shock is given. So this is when you are going to defibrillate a patient. If a patient has the VFib, ventricular tachycardia, ventricular fibrillation, you are going to defibrillate. So this is what you do. So you set it, the machine to charge at 120, the cardioversion machine to charge at 120 to 200 joules. That's the charging rate. And then we deliver 1 shock. You deliver 2 shocks, and then the CPR is resumed immediately. So if they are going to ask you, they may not ask you about the CPR. They may not ask you about what's the name? They will not ask you about the shock. They will ask you about CPR. They want to know how long should you do CPR for? NCLEX like to question that. You don't have a limit of CPR until they tell you shock is advised. So until shock is not advised, you do CPR. Shock delivered, immediately continue CPR. So mind that word immediately. That is the only place you will see that immediately and pick that answer. If it's not CPR issues and you see questions that say immediately do this, or I will always do this, be mindful of those answer options. They are confusing. So before defibrillating a client, be sure that the oxygen is shut off to avoid the hazard of fire. And be sure that no one is touching the bed or the client. So if the patient is getting oxygen and you are still ambling, you are providing CPR, you cannot be you are providing the CPR and they are giving the oxygen. Then the moment they tell you shock is advised, everybody has to stop. You don't want to keep pumping the ambu bag, giving the oxygen whilst that's synchronized, whilst that radiation is being shocking the patient. You can cause a hazard. That means there's a tendency of it catching fire because that machine is electric. It has magnetic fields on it to provide shock. That's why they don't even want anybody to touch the machine or the patient. When they tell you shock is advised, everybody stop. So that is it for now. Well, can we take a break?
Okay.
Yeah. let's take a break and come back. I need to drink water. Gertrude, are you with us?
Please.
Okay, you are sleepy?
No.
Okay, yeah, we are going to take 10-minute break and then we come back and finish up. I know we sometimes, most often we close a little late than we say. Our time is to close at 8 o'clock, but sometimes sometimes we stay over to talk more. Okay? Yeah,
Okay.
so we'll take a 10-minute break. We can come back. Oh, come back, it's already 8 o'clock. Simone, are you still at work?
Yeah.
Okay. All right. So that means I will not be able to go into the cardio diseases today, but I have a complete one of it. I can send you guys to read it, and then you let me know if you have questions. But I really wish to discuss those conditions. I was just about starting the coronary artery diseases. So how about we move into 8:30? Would that be okay for you guys if we close at 8:30? Will 8:30 be okay?
Yeah.
Okay. So we'll come back at 50. We'll come back at 8 o'clock and then we'll do 30 more minutes of discussion. So that I'll go into the cardiovascular conditions. These are all tests. Okay. Okay. So I see you at 8 o'clock. Okay. Bye. Hi, everyone. Are we back? Are we back? Can we continue? Gertrude,
We can.
you back?
Yes, please.
Okay. So the next one I just want to talk about is pacemakers. So pacemaker, we have the temporary or is a permanent device that provides electrical stimulation and maintains the heart rate when the client's intrinsic pacemaker fails to work on adequate rate. So we have the pacemakers that they put it in when the patient heart fails to work, mostly in heart blocks on the EKG strips. When the patients start having the heart blocks, they need pacemakers. When I discussed the EKG rhythms, I didn't talk about the heart blocks. Those were the only ones I didn't finish up with, but I will still catch up on them with everybody. So we have it's either a permanent one or a temporal one. So if the patient condition demands that they have a temporal one to see how the heart pick up on its own, they'll put a temporal one. So we have the first one, that is the synchronized pacemaker, and it sends the client, if it sends the client's rhythm and paces only if the client's intrinsic rate falls below the set pace rate for stimulating depolarization. So this one is a synchronous one. It synchronizes the pacemakers, it synchronizes on demand, and it senses when the client's heart rhythm and the pace, and it gives it spacing when the client's intrinsic rate, like the original heart rate, the original pacemaker of the person or the naturally inbuilt pacemaker system of a patient falls below the normal rate. So if it's not able to work, the heartbeat is not able to get to a normal level and the patient is having breathing, it will push it to stay to the normal level. So we have the second one, that is the fixed rate. So the first one is a demand rate. The second one is a fixed rate pacemaker. So this one is regardless of the client's intrinsic rhythm. It is used when the client is asystolic or profound bradycardic. So if the client has a natural bradycardic state, so for one or two reasons, you just had your heart rate drop for, let's say, a week, and they don't know what is causing it, then they give you the demand one. That means it's on demand. You needed it to be able to get to the normal one. That has not been your normal. We have the natural one that other people have a fixed low bradycardic state. Naturally, your heart rate is low. So at a certain age, your heart rate keep dropping to super abnormal. In that case, you're going to need the fixed rate. So they give you a fixed pacemaker that will keep your heart rate fixed at a certain range. Usually it's going to be on a range. It's not going to be like the normal one that you have that you can run and it go up, you can walk and it come down, you can sleep, it come down. They will set it to say, okay, your heart rate should be between 80 and 85, and that's what they have set the pacemaker to do in your heart. Then we have the overdriving pacing suppress, and this one suppresses the underlying rhythm in tachydysrhythmia so that the sinus node will regain control of the heart. And then, so this one, we have the one that they put it in that help when there's tachycardia. So the first two talks about bradycardic state, when a person is brady and needs a pacemaker. But the third one talks about when a person has tachycardia and needs a pacemaker to help reduce the heart rate to a normal level. So pacemakers are either to bring the heart rate to normal, are either to push it from brady to normal, or to bring it from tachy to normal. Those are mostly the reasons why people need pacemakers. Now we have the temporary pacemakers. We have the non-invasive transcutaneous pacemaking. So this one is non-invasive and is used as a temporary emergency measure in the profound bradycardic or asystolic client until invasive pacing can be. So this one is a machine. They use that one as a temporary. So when a patient comes and the patient has a bradycardic state, a systolic state, then they check on the EKG rhythm and it's asystole, they see it's just straight flat line. The heart rate is super low. They just put this one as a temporal one. They put it on your chest. You can see it. It's non-invasive, it doesn't go into your body. It's a temporal one. So they put that one right now, and then it jumpstarts your heart rate. So in the next few hours, they are working on getting you a permanent one that will be able to work within you, that you can move with it. But this one is just for emergency needs. That's the temporal pacemaker. And what is that? So for what you should do as the nurse, you have to wash the skin with soap and water before you apply the electrodes. It is not necessary to shave the hair or apply alcohol to tincture to alcohol or tinctures to the skin. It's not necessary. You don't need shaving with this one. It is going to read straight from the heart, and that's what it's set to do. It's not set to pick up any other thing that is outside from your heart. It will not pick up your hair. So if the patient is so hairy around the chest, you don't need to bother about shaving the hair. So that is it about the temporal pacemaker. So no washing, you do need to wash the area, but you don't need to worry about shaving the area. So you place the anterior electrodes between V2 and V5. This one is the EKG. I don't want to talk about it because it's going to confuse you. This one is the EKG rhythm. When you do an EKG, you put one here, and then you go on the left side all the way to V6. Those are EKG electrodes. So they are teaching you how to put the electrodes to be able to capture activities of the heart when you are putting a temporal pacemaker. Now let's talk about the invasive pacemaker. This is the one most patients here has. This is the one most people will have because they send it home. So they do an invasive procedure and they put it in. So when you see the patient that tells you I have a pacemaker, you will see it placed here. When you touch it, you can feel it. You can feel the spacing. Sometimes you are able to just see that around that side of the patient chest has a circular thing in there. So you can see it, there's a raised portion of the skin. So you can actually see the the invasive one. The patient carry it home and they stay with it for life. Most of them stay with it for life. In that case, you have education to tell a patient they are not supposed to pass by metal detectors. That would be the number one question. NCLEX likes to talk about it. That's why I jumped to that. They want to know what you will tell a patient that has a permanent pacemaker, because the patient live life normal. It make you feel okay. Your heart doesn't race anymore. If your heart start racing anymore, then you are worried there's a problem with the pacemaker. I have that in the notes, how to care for a patient with, or what to tell them, how to educate them. So the patient with a pacemaker, we are not so worried about how the procedure is done to place it. You have to be worried about the teaching, what you tell them. And take note, before we get to the teaching aspect for those patients with a pacemaker, just know that if a patient has a pacemaker, it's a metal that they put and it's a permanent one. The patient has to live with it for life. It doesn't stop their daily activities of living. It does limit them on certain things they cannot pass by. You can't pass by a metal detector. So you walk to the store, they tell you this store has a metal detector. You are not allowed to cross over that door. The door that has those signals, that signal stuff and waves, you are not allowed to do it. And before they do cardio synchronize the cardioversion and the defibrillation, they are mindful of that one too. So those patients, they have another procedure to do those things with them. You can't do everything with those patients because of the pacemaker. Now, the vital signs are monitored and cardiac monitoring is done continuously for clients with a temporary pacemaker. So that's the temporary one. For the permanent one, they roam with it. Like I told you, they feel good. It's part of them now. They're going to do it for life. So they carry that permanent pacemaker for life. So you can monitor your vital signs every minute, but you just feel good and you go home with it. But the temporary one, the patient has it for temporary reasons and they are working on either reversing the cause of it or giving the patient a permanent one. Now let's talk about cardiovascular diseases. So we have coronary artery disease. So I really didn't show you a diagram of the coronary arteries, but when you look on a diagram of the cardiovascular system, this is actually supposed to be a review. Presumably you have a baseline of the content in mind. So this one is just to give you a recap of what you should have known already. So when you look at the coronary artery, is in the heart and is the arteries that carry the nerves and the impulses and the blood work all around the heart. We have a coronary artery system of the heart. I have an image of that, but I don't have it well organized right now. So we have the coronary artery disease is narrowing or obstruction of one or more coronary arteries as a result of atherosclerosis, which is an accumulation of lipid-containing plaques in the arteries. So if we remember our anatomy and physiology, that tells you that atherosclerosis is narrowing and hardening of the arteries. That's the coronary arteries. So coronary artery disease, the arteries become diseased when they start getting hardened. So when something starts getting hardened, they start reducing in size and in shape. So they say accumulation of lipid containing plaques in the artery. So anything that is disease, it doesn't work as it should. So it starts becoming hard and it narrows in function. That will also reduce a lot of stuff in the heart, and that will cause other things. So a patient presents to you, how will you know this patient is presenting signs of coronary artery disease? So I'm jumping straight to the signs and symptoms. So what you will see is there will be possibly normal findings using asymptomatic periods. They have periods that they wouldn't notice it. Sometimes it is noticed through diagnostic tests. So the asymptomatic period, you wouldn't notice it. Some heart conditions, most heart conditions, before you notice it, it has gotten so bad. So coronary artery disease possibly may not be symptomatic. The patient will not have any symptoms. There will be chest pain. So the patient will come to you and complain of a chest pain. Palpitations. So when you check the heart rate, you see that the heart is really pacing up faster. Dyspnea. The patient will have difficulty breathing. Syncope. The patient will tell you, I passed out. I passed out. So if I pass out, I black out. That's the word they like to use here in America. I black out. Cough or hemoptysis. So the patient is coughing and there's blood in it. You know, when you talk of cough, cough is respiratory system. I remember I had talked about that. But remember this cardiovascular system has a link with the lungs. So when the blood moves from the heart to the lungs, get oxygen and come back to the heart. So the two are interconnected, they are interrelated. So when there's cough and blood, you want to suspect coronary problem because the patient said chest pain and dyspnea. So anytime there's shortness of breath, even though we know the respiratory could be the problem, but heart too is being assessed for shortness of breath problems. Now we have excessive fatigue. I get too tired. The patient will tell you, I get too tired. So usually you will not just look at these patients and know what is wrong because these are other symptoms of other disease problems. So on the diagnostic, they will do an echocardiogram. This is just the ultrasound of the heart. I had talked about this already. Cardiac catheterization. So if they do the echo and they realize that there's hardening of the arteries in the heart, then they're going to go further to do a cardiac catheterization. They'll catheterize, they'll put a tube through the heart to get to the coronary arteries to try to open them up. They're forcing them to open. So blood lipid levels. So this one will be done in the cholesterol. This is where a patient will tell you. So if a patient tells you, I have a history of high cholesterol and I've been taking medication, but lately I've been passing out frequently. I've been having shortness of breath. And today my heart just started aching. I've been having chest pain all day. That's how NCLEX will present a patient to you. They are not going to have the patient come and tell you I have coronary artery disease. The patient will tell you, I've been taking this particular medication. I've been taking losartan. I've taken that medication for 2 years. And lately I've been having syncope. I passed out 3 days ago. And today I wake up, I have chest pain. They wanted to know where that problem could be coming from. That's the trick NCLEX use. So they describe the symptoms and they want you to be able to know that this is the problem the patient has and what you should be able to do first. So in that case, you need to know that this is a coronary artery problem to tackle it. So interventions is what you, the nurse, would do. And this is what NCLEX also focus on. Apart from you identifying what is going on with the patient, they want to know what you will do. So you assist the client to identify the risk factors, and that can be modified and to set goals to promote lifestyle changes. So most of these patients with coronary artery disease will have cholesterol problems. So patients who have cholesterol problems are number one at risk for coronary artery disease. So stress that you want to tell them about dietary management and lifestyle changes. Those are serious things they need to look into. You also want them to work on exercising themselves. Smoking cessation, most of them, they smoke. So when a patient smokes, the smoke keep going into the lungs and it's causing hardening. It keep causing hardening of the lung muscles and thickening. So in that case, you can get coronary artery disease because the lungs too is impacted. And we have pulmonary circulation also impacted. We have the surgical procedures that will be done for a coronary artery disease. Like I told you about the cardiac catheterization before. We have the percutaneous transluminal coronary angioplasty. So if you don't know what this is and you see this one on the NCLEX, or they tell you coronary angioplasty, you want to know that it's a problem that a patient has a coronary artery problem. They want to work on that. So the medication you want to give is nitrates to help with dilation, calcium channel blockers to reduce vasospasms. So we know calcium has to do with spasms. So if you have problem with calcium, you'll be having spasms. So you want to give calcium channel blockers. Cholesterol lowering medications, like I mentioned before, patients with that will have problem with cholesterol. So you want to think, anytime you see coronary artery disease, start thinking of problem with cholesterol. Now, the next disease problem I want to talk about is angina. So angina is a chest pain resulting from myocardial ischemia caused by inadequate myocardial blood supply and oxygen. So if there's reduced blood supply to your myocardium, you start having sharp chest pain. So it's caused by an imbalance between oxygen supply and demand. So there's not enough oxygen supply that is being supplied to your heart muscles, and your heart muscles need more oxygen. So if the heart muscles is not getting enough oxygen, this is where you start having the chest pain. So most people will present to angina, and most people who present with angina is as a result of reduced blood flow to the myocardium of the heart and oxygen supply. So the causes will include obstruction of the coronary blood flow, which result in atherosclerosis. So this brings us back to the coronary artery disease we just spoke about. So you see they are linked. So a patient with coronary artery disease can present to you today with angina, and it's because the blood supply to the myocardium is reduced. That's why today they have an angina, because the complaint is going to be different. Now I put a note here that the goal for treatment for angina is to provide relief from the acute attack, correct the imbalance between myocardial oxygen supply and the demand. So there's imbalance, the supply of oxygen and the demand. So the amount of oxygen that gets to the myocardium is not enough. The heart need more, the heart muscle, which is the myocardium, need more oxygen, but the oxygen that comes to it is not enough. So because that oxygen is not enough, there's no balance to it. So if you don't give me enough, how do I function properly? So we are not balancing well. So you want to be able to know that there's an imbalance, and this prevents the progression of the disease and further attacks to reduce the risk of myocardium. So your goal for this angina is to be able to help supply the patient myocardium with enough blood. And this will create a balance between the oxygen supply and the demand for oxygen and blood supply in the myocardium. Now we have the pattern, the types of angina. We have the stable angina. This is also called exertional angina. This occurs with activities that involve exertion or emotional stress. So emotionally, they come to tell you, oh, your sister just fell on a motorbike. Emotionally, all of a sudden, this is a sudden news you just heard. So this can cause, but this one is emotional. So this one is usually, yes, they tell you that news, and you are somebody who already have problems with anxiety or all those things. So this one, it will just continue. So you will have that, and it's usually relieved by nitroglycerin. So this one is not like a sudden one that come and go. The unstable one is the one that is not stable. But the stable angina is something that you have it, and it occurs when you get tired, when you are emotionally disturbed. So it's being relieved by nitroglycerin, and usually it has stable pattern, onset, duration, severity, and relieving factors. So you know that anytime I get this anxiety, this pain in my chest, I take what's the name? I take, let me say, a cup of ice water, and it comes down. So you will know your relieving factors. So the patient knows that I have stable angina. My angina is stable, but I know the relieving factors, what I will do. So I'm stressed today, I'm emotional today because I just lost a family member. I get angina, but I know the relieving cause. That's what I tackle it with. Unstable is associated with worsening cardiac ischemia. Cardiac ischemia means cardiac death, muscle death, and this occurs with an unpredictable degree of exertion, emotional occurrence, duration, and severity over time. So the time and the severity of it is not able to be determined, and this lasts longer than 15 minutes. So pain may not be relieved with nitroglycerin. So this is unstable one that gets set in. It's not stable. You don't know when it occurs. This one, the first one, stable, you know when it occurs. It usually stays for 5 minutes, and within 5 minutes, you expect it to go. So after 5 minutes, it doesn't go away, you are concerned. Something different might be going on. We have the variant angina. This one is called a paroxysmal or vasospasmic angina. So NCLEX like to use this word, presmental angina, or they like to use this word presmental. So the patient presents to you, complain that I have presmental heart problem. They don't want to say angina, because if they mention angina, you will know what it is. So that those words that seem a little weird are those you take note of when you are studying for NCLEX, because they like to use them. They don't want to use the straight one, and you know the type of angina it is. So this one is, it results from coronary artery spasms, may occur at rest. Attack may be associated with ST elevation noted on EKG. So that one you have to, you can be resting and you still have the pain. You don't know the cause, nothing caused it, but that means something didn't go well with your heart. So your heart muscle, your arteries are spasming. So when they are spasming, you have that pain. We have the intractable angina, and it's a chronic incapacitating angina unresponsive to intervention. So you can give all interventions for this particular angina, but it still does not respond to treatment. Now, assessment findings, what will you know? Because I told you, NCLEX, they don't like to say this is it. They wouldn't mention angina, but they are giving you signs and symptoms. So patient comes to you, the first complaint you are going to hear and think this may be angina is, I have a sharp chest pain. My pain developed one time, sharp. It was just one time. It's like somebody kicked it and it started. Pain usually is described as mild, moderate, substernal, crushing, squeezing, and it may occur. So the patient will present to you and say, I have this pain that just started this afternoon about 30 minutes ago, and it started mild and it's kind of getting heavier now, or it got heavier in like 15 minutes. And since it came, it's been squeezy. They describe the pain, it's been squeezy and it's kind of crashing. I feel it's just at the point of this place. That's what is you're gonna think. There's something wrong in the heart in the first place. They tell you the pain may radiate to the arms, legs, jaws, neck, or back. So if the patient tells you that pain is here, but it's radiates to my neck, it moved to my arm, moved to my leg. Pain usually lasts less than 5 minutes. However, pain can last up to 15 to 20 minutes. So they tell you, for all day today, I've been having that pain. It's like every 2 hours, I get it and it goes away. I don't do anything to it. I don't treat, I don't take any medication. I only have aspirin at home. So when that pain comes, I just take the aspirin, and I took the aspirin twice and it stopped. But I realized that it's too much. So I decided to come. Those are the symptoms. So the patient will present to you and then ask you that, and they want to know what you will do as the next. So remember, so there will be pain is relieved by nitroglycerin or rest. So mostly patients that present that, when they do the assessment, they give the patient nitroglycerin. Remember, NCLEX want to know if you understand how nitroglycerin works. So nitroglycerin, you are not supposed to touch it. If you touch it, you're going to feel a fainting sensation. You're going to feel like you also go in a syncope. You're also going to pass out a little. You are not supposed to touch it. So the patient take it and it's sublingual. Nitroglycerin is given sublingual under the tongue, and it absorbs. When it absorbs, it kickstarts the heart and clears out every spasming that is being caused in the heart. So if that pain is relieved by nitroglycerin, yes, you can give nitroglycerin every 5 minutes for up to 3 times, and you look for further treatment. So there will be dyspnea, the patient, there will be pallor, sweating, palpitations, and tachycardia, dizziness, syncope, hypertension, and digestive problems. Now the diagnostic test to be done will be EKG. They will do stress testing, troponin, and cardiac enzymes. The nursing intervention is what you, the nurse, will be doing. You are not going to be worried about the EKG, even though you will get it. So I have EKG all the way to the end of my discussion, because that is not going to be a priority. Don't forget to pick EKG as your first priority, because if you pick it as your first priority, you will get it wrong, because nursing intervention will be to assess further. You want to assess the patient pain, and then you want to start pain relief measures. You administer oxygen by nasal cannula. You assess the vital signs. Ensure that the bed rest is maintained, and the client should be in a semi-phallus position and stay with, you have to stay with clients. Now, for the sake of those of us here, Gertrude, for the sake of NCLEX, just to let you know, you never leave your patient if the patient has any new symptom going on. So I did work in Ghana as well, and I understand that the practice goes far different from here. For the sake of NCLEX, you have only that patient on the NCLEX book. You don't have any other patient, so it doesn't matter how much time you are spending with that patient. You have to stay with the patient. You don't care whoever is the other patient dying. This is the one you identify there's a problem with. NCLEX wants you to spend all the hours of your shift with that patient to care for that patient. So you don't move. You stay with the patient because the patient might be anxious for chest pain. They might be scared. So you don't leave. You have to stay with the patient and continuously monitor their vital signs. Now, following an acute attack, you want to assist the client to identify angina precipitation causes. So if the patient has a lot of stress on them that is causing the angina, you want to tell them, you want to instruct the client to stop those activities and to take rest when chest pain starts. Oh. So the next problem I want to talk about is myocardial infarction. So we have the treatment for coronary artery disease. So under coronary artery disease, we talked about angina and the types of angina. And the best treatment is to give nitroglycerin is given every 5 minutes sublingual for 3 times. And then that's 15 minutes. And you stay with the patient, be supportive, you continuously assess the pain, you teach the patient to be able to identify causative factors that cause it. So if it's stress, you relieve the stress. You educate them how to do it. That's what NCLEX is demanding of you. And there may be a surgical procedure, that's the angioplasty thing, the percutaneous angioplasty, and then you can give antiplatelet that may be administered to aggregate and reduce the risk of developing an acute attack. So antiplatelet like aspirin. So after you've given the nitroglycerin, you can still give aspirin after a while if the nitroglycerin is not reversing the effect. Antiplatelet is aspirin, and that will help. Any question?
Would you have, if you give the nitro thing and you give an aspirin, would that be too much? If the patient has is already on blood thinners?
So if the patient is already on blood thinners, you are not going to give aspirin. But remember, this is a patient with coronary artery, and coronary arteries always have hardening, atherosclerosis. They become hardened, and there's a plaque. So you need blood thinners to be flowing. So if the patient has not been diagnosed already, and the patient is coming to you, and this is the diagnosis they have given, the first thing they want to give is antiplatelets to help thin the blood. So if the patient is already on blood thinners, a chronically diagnosed coronary artery problem, the patient will be on blood thinners, so you are not worried. But remember, the half-life for nitroglycerin is short. So when you give it, within 5 minutes, it has finished working. That's why you are allowed to give it again if there's no relief in pain. So nitroglycerin is short-acting and it just works fast. But if it's coronary artery that is diagnosed, you want to give antiplatelets to be able to help with blood thinning, to help thin the blood so that they will not be clotting. So it's antiplatelets that you give, and you can give aspirin at that point, even with the after giving the nitroglycerin, you can give aspirin. So nitroglycerin is short acting. You're making noise. Now we have MI. Myocardial infarction, it occurs when the myocardial tissue is abruptly and severely deprived of oxygen. So just think about MI, muscle death. And I told you the cardiac markers already. We have the CKMB that you use. So NCLEX will present with you with the values, the normal values for the CKMB, or they'll present with you EKG strip like I did the last time. And they want you to identify. If you remember the readings, I gave 4 of them, and I wanted you to identify which one was the problem. So NCLEX will either give you the CKMB levels with the normal and the abnormal. They will give you troponin test that was being done. They want to know if you know that troponin is a cardiac marker to identify the function of the heart muscle. So those are the things NCLEX will take you into. So if you know MI is cardiac death, we are done with the topic. So let's continue.
So the troponin, I know sometimes where I work, if they suspect any form of myocardial infarction or stroke-like symptoms, they would order troponin.
Yes. So it's a cardiac marker. But that's what I'm telling you. On the NCLEX, don't worry too much about how you see them order. Sometimes it's not even MI, but they still order trop because the patient is just complaining of chest pain. They have done the EKG. EKG is normal, but the patient complaint is that I've been having that and I have fatigue. You understand? The complaint does look like MI. That's in the practical world. So the facilities have standard that if the patient is giving you this complaint and this complaint, and 3 of those complaints come out, as per our standard, you have to do troponin 2 times to confirm. It may not be MI symptoms, the doctors know, but this is a protocol that comes with chest pain. We will do it that way. Like some other facilities have a protocol. The moment you complain of abdominal pain, if you have abdominal pain, distended, non-distended, so far as there's abdominal pain, our treatment is to give you Pepsid, Zofran, and you go for CAT scan. That's what they're going to do. Some other facilities will say, okay, we'll give you Pepsid, Zofran for the pain, and then we'll make you go for ultrasound. Others have the policy that they can do ultrasound and still go for CAT scan. Others have the policy that you do ultrasound until you suspect a problem. Then you go for CT. But other people have it straightforward to CAT scan. So those are facility standard. That's why I tell you, whatever you see in practice, don't bring it to NCLEX because it's not going to help. So in the case of my cardiac infarction, they do the trop to just make sure the cardiac muscle is working. So troponin is a cardiac marker and CKMB2 is a cardiac marker. But I would, if they're doing CKMB and troponin on the NCLEX, they ask me the question, which one I'll follow up for MI, I'll go for CKMB. Okay. I'll go for CKMB before troponin, even though the 2 of them, they are cardiac markers. So when it comes to...
I'm sorry. What's the name of that one? Not the troponin, what's the name of it?
The CKMB.
Yeah.
Let me get it. I don't remember the scientific long name. It's a long name. Is it something kinase? It's an enzyme. Usually they relate it as an enzyme. I think when I was discussing that, we were on. You know, fine. Go out. Okay. I'm going to give you candy. Go. Oh, where is it? Yes, it's here. Creatinine kinase.
Okay.
You see, creatinine kinase myocardial muscle. CK myocardial muscle. Okay.
Yeah.
So it's more.
You said in the case of a myocardial issue, this would be first before the troponin.
I didn't hear you.
You were saying earlier that in the case of a myocardial infarction and the NCLEX, this would be the answer over troponin. Like, which one would you do first? You would do the CKMB over the troponin.
You will do both.
Yeah, but this one you would do first.
Yes, this one is what they use more of MI. You are more concerned of this one with MI than troponin. Even though they are both going to be a problem to note, but the moment you identify that this problem is MI, you see this one is creatinine kinase myocardial. So that means it's straight of a myocardial function. than the trop. Troponin is a general for the heart, but for the this one is specifically for MI. So if you have the two of them, like I told you, if you have hypokalemia and hypercalcemia, you go for the potassium for heart problems. If I have troponin and CKMB for myocardial infarction, I would go for CKMB before I come back to this, even though I need the two of them.
Okay.
Okay. And you see, I have the normal levels there. They have levels for men and levels for women. So when I send you this one, you want to take notice of that. What again? Okay, so I'm going to jump it. Okay, so myocardial infection is what they will term as STEMI. STEMI. So STEMI will be ST elevation myocardial infarction. Emilia, so if they ask you a question and they say the patient had a STEMI, within 3 hours, the patient should be able to get to cardiac lab, CAT lab, for them to do a cardiac catheterization to see what is going on. So if the patient has a heart muscle, that can cause heart attack. So usually they rush the patient to care for the patient. So they will tag the patient as STEMI. I don't want to add the N because sometimes it's ST elevation. Non-ST elevation, that means there's no problem. But when you have ST elevation, that's STEMI. So we take the N out and we have STEMI. ST elevation myocardial infection. So that's what the STEMI stands for. It's a medical emergency. The moment they realize that, they do the EKG and they see the ST wave from SQRS to T. They see that wave elevated. Instead of being a little shorter, it goes up higher. Then there's a problem with the myocardium, the heart muscle that is supposed to help push the blood to the whole body. There's a problem with that. So the location will be obstruction of, I forgot what this LED actually resulted. So let's leave this side out. Let's talk about the risk factors. What make you at risk for myocardial infarction? What make you at risk? So people who have atherosclerosis, coronary artery disease, elevated cholesterol. So patients that have a history of high cholesterol, they are at risk. Those who smoke, they are at risk. Hypertension, obesity, physical inactivities, impaired glucose tolerance, and then stress, too much stress. So troponin levels for 3 hours, it will be elevated within 3 hours. And it can be elevated for up to 7 to 10 days, okay? So the CKMB is an isoenzyme. It's isoenzyme. The peak elevation level occurs 18 hours after the onset of chest pain, and it returns to 48 to 72 hours. So this is the only difference between the troponin and the CKMB. Troponin will be done first because within 3 hours of the heart muscle death, you are going to start noticing a problem with the heart. But the CKMB elevation starts in 18 hours before the heart is able to detect that there is a problem. The enzyme of the heart is able to detect that there's a problem. So that one takes time. So 18 hours for CKMB to be detected as positive. But the troponin takes just 3 hours so to be detected. So that's why when a patient complains of sharp chest pain, you see that the first lab they will order is the trop. And then within 18 hours before they can get a good reading, either the CKMB is normal. But the CKMB is more of a cardiac marker than the trop. But the trop is an initial first test you will do. Do we get a difference? Do we get a difference here?
Yeah.
Okay, so I have the whole diagnostic studies here. These are all diagnostic studies they will do. You do an EKG, you do white blood count, there'll be an elevation, and you do cardiac catheterization procedure. That's the one I said they have to send the patient to cath lab. According to the American Heart Association, patient has to be in the cath lab within 3 hours of presenting the complaint to you. And if it's MI, the symptoms have to be within 3 days. So if the patient come in and says, I've been having this for 5 days, then that period is past. So the patient can even have a drooping face, can have a real stroke and whatever, but those causes at that time are irreversible. But within the first 3 days, 72 hours is reversible if you work with the patient within 3 hours. The moment you receive the patient, American Heart Association demand that within 3 hours, if the troponin is done, you should be able to get the patient to the cath lab for them to do a procedure, the percutaneous coronary angioplasty. They put something in there to open up the artery that is being blocked and causing all that. Now the assessment findings, this is what you will find in the patient. This is what you will find in the patient, or the complaint the patient will give you when you assess the patient, subjective and objective data collection. This is what you will see. There will be pain. So you want to note that the first complaint you get is pain. Clients may experience crushing substernal chest pain, and pain may radiate to the jaw, back, and left arm. So note these 3 areas. NCLEX is presenting with you a client that just came in and said, I have pain that started 1 hour ago from my chest. It starts from this left side of my upper chest, and the pain radiates to my jaw here, right, left jaw here, and it moved to my back, and this arm feel weird. Those are the symptoms the patient is telling you. So the pain lasts for 30 minutes or more. And then there'll be nausea, patient may be vomiting, diaphoresis. You see the patient sweating for no reason. Dysrhythmias, feeling fear and anxiety, impending doom. So this is where they want you to stay with the patient. You cannot leave the patient at this point. So you see that they are feeling that I'm dying because my heart is not working. Something is definitely wrong. So the nursing intervention is to obtain a description of the chest discomfort. You ask further questions. You have to administer pain medication since there's mention of pain. Now note another thing on the NCLEX. Pain management is key, and pain is what the patient tells you. Don't adjust anything about pain. On the NCLEX, you have to get the pain reporting from the patient on a scale of 1 to 10. So pain is never adjusted. The patient tells you it's 5, and you look at the patient and this patient is just lying. Your mind tells you this patient is lying. But listen, on the NCLEX, if the patient tells you pain is 10, pain is 10. Just take the question like that. So in your interventions, you do the EKG, you give the patient oxygen, you check the patient blood work, check temperature. Now, another thing I want you guys to note, NCLEX have realized that because of COVID, everybody is taking temperature weird. This is not part of this lesson right now, but they have realized that everybody is taking temperature by, the gun thing, right? Everybody is using the gun to check temperature on the forehead. So I'm giving you assignments, okay? If everybody's hearing me. When we come on Thursday, I want you guys to tell me the correct or the most reliable method of taking temperature. Okay, both in adults and in children, the most reliable method in doing temperature, because NCLEX have realized it. I have a couple of people tell me how they ask about the temperature that will process that will be accurate, because now they see that everybody is getting it from the forehead. Okay, that's just an assignment. So Thursday, please remind me and tell me the most reliable method that we use to take temperature. Simone, oh, you know it already. Do we know, or we are going to search for it?
All right. for
Okay, thank you. So I'm going to talk about heart failure. I don't know what our time is. Oops, I'm sorry for keeping you long. Can I stop here?
yeah.
You don't stop me with the time. I don't look at the time usually. I'm so sorry for keeping you long. So with the patient who has an acute episode of MI, you want to maintain them at bed rest. You want to allow the client to stand, to void or use a bedpan. You want to provide range of motion exercise to prevent thrombus formation and maintain muscle strength. You want to progress to dangling legs at the side of the bed or out of bed to chair for 30 minutes, 3 times a day as prescribed. And then you progress to ambulation. This is teaching. Nursing intervention. You want to teach the patient how to start movements. So they shouldn't just get out of bed and start jumping or start running like you were sleeping and you wake up and you are late for work. I know how that feeling is. So you want to monitor for complications. You want to administer angiotensin converting enzymes, ACE inhibitors, angiotensin receptor blockers. That's the ARBs, calcium channel blockers. So basically blood pressure medications you want to give to the patient. And then you encourage the patient to verbalize their feeling. That's where therapeutic communication comes in. So NCLEX can use MI, myocardial infarction, and they put it as a therapeutic communication. So the patient is communicating with you, expressing their fear for this impending doom they are feeling. What will you do for the patient, or how will you respond? So know how to educate patients with MI, know how the diagnosis is being done, and know the time window period for troponin, which is 3 hours. Troponin will start showing abnormal labs, and then the time for the CKMB, which is more of MI, but that one starts in 18 hours before you can identify it. Any question for the day? Do we have any question?
No.
You said? Simone, I didn't hear you.
No, nothing.
Huh?
No, nothing.
Oh, okay. I thought you were asking a question.
No.
Gertrude, any question? Any question, Gertrude?
No question, please.
Are you understanding the teaching? Do you have any concern?
Yes, after going through, I'll be fine. I understand what you just told.
Okay. So I'm going to send it. The Google Classroom, I'm going to try to put this one there. I've been trying to upload documents in there for last week. It wasn't going through. But this I'm going to try to see if I can upload it. If I cannot upload it, I'll just paste it. If I send this to you as attachment, will you be able to go over it as well? I want something that will be able to be easy for you to get access to. Hmm? Did you hear me? Okay. So we are going to end our class. Okay. So Thursday we are going to meet, and next Monday too. Next week, Monday, Tuesday, I'm not available. So can we do Wednesday, Thursday for next week or no?
Yeah.
You said?
It's a yes for me.
I didn't hear you.
I said that's a yes for me.
Okay. Gertrude, any concern?
I'm okay with that too.
You
No,
okay?
I'm okay with that too.
Yeah, I'm
Yes, please.
working on it. I think I'm trying to do something with your timing because I feel bad for you. Emilia, any concern? Because I know how it feels to leave your sleep and you're just dozing, or you'll be busy all day and at night you want to rest. Okay, so I'm going to also work on the assignment for this week. I have not posted it yet. I was waiting for Simone's own to be able to mark it. So she sent it to me. I'm going to mark it after I finish this lesson. I will send it out tomorrow. Assignments I usually do Monday through Sunday. So, and it's 75 questions. Listen, my purpose for that assignment is not for you to answer and get like 50 out of the 75. That is not my aim. If you answer 50 and if you get 50 out of 75 and you don't understand the basic topics the questions are mentioning, please just take a book. I don't care if you don't submit the assignment to me on time, and then you are able to go over the 75 questions, and there are topics that you are cross-matching those topics and you are learning them to be able to answer these questions. Even if you're not learning them to answer these questions, you just see the topic and you are learning to understand those topics. That is fine with me. So you can get that, you can owe me the assignment, but I'm not interested in the bigger grade you get. I'm interested in you understanding what the question is telling you to do. So if you don't understand what the question is asking, the question is talking about heart failure, and then you don't know the most immediate thing you tell the patient. Go and read about heart failure and the education you give to a patient about heart failure before you answer those questions. That's my main aim for you guys. My main aim, because students are fond of answering questions. So you see somebody answer 1,001 questions. The person will answer 900 questions. And then their books are filled up with questions because they think like, if I answer the questions, I get the rationales. It's going to help me. That's not going to help you if you don't know the basic content of your nursing, because that's not how NCLEX want you to behave. They don't want you to just know the answer. They want you to understand why you are answering this as the correct one. So don't wait for me to send you the answers and you read the rationales. I want you to be able to understand the topics that come with all the questions and how to manage each of those patients in there. Okay? All right. So on that note, we are done for the day. Okay? Simone, are you available to talk to me? You want me to call you on phone? Or
No, not tonight. Can we talk tomorrow?
Yeah, I'm home tomorrow. All day.
Yes.
All day. All I'm busy doing is NCLEX stuff. So I'm home tomorrow. Just text me and let me know so that I'll make up time, because my phone, I try not to pay too much attention to the phone because I have a lot of things to do. And with the kids, I try not to let the phone distract me. So usually, I know Emilia too was trying to reach me since yesterday. It's really hard.
Yes.
And I did see that it's like you sent me a message on Messenger, right?
Yes.
I see that you sent me a message, but I stopped using Messenger. I really don't reply because I have so many Facebook friends. They want to chat all day and it's a waste of time. I deleted it on my phone. But when I have a computer, I see the name appears that somebody sent me a message, but I don't go to open it. So I'm sorry I didn't reply. Just text me on WhatsApp. I also have a control on my phone. When that time comes, those apps that are keeping me busy, they all cease to work so that I can have a good night's sleep. So if you send me a WhatsApp message after 11 p.m., unless I activate to read it, because I'm also a mother, besides all these things, I'm a busy woman. So I do a lot of studies. So I don't want to be distracted all my life with electronics and phone. So because of that, I have a lot of settings that also help me keep up with my husband and my kids. Yeah, so I'm so sorry. But always when you text me, I will definitely reply you. Anytime I wake up in the night, I activate the WhatsApp to get messages, and then I just put it back off. It goes back off on his phone. I set it for the time. When it's 5-10 minutes, it goes back so that I don't get. And sometimes people call you from Ghana because they wake up early and they are just pinned on your phone.
Very annoying.
And it's so annoying. So I'm so sorry, but it's okay. I reply. Email and WhatsApp, you can never go wrong with me on that. That's my communication methods. Best number one. And text message, phone text. That I'll get back to you. Yeah. But phone call sometimes it won't go through, especially when I'm at work. We don't have a network on my floor. So my phone doesn't work when I step at work. I can only call my family with a work phone. So it's also another challenge for me. That makes me not interested in the calls so much. But WhatsApp, you get me. Okay. So we'll call it good night. Emilia,
Yes.
want to talk to me too, or you just wanted to
Yes.
clarify the class?
Yes, a little discussion. So when you are free.
Okay. So when we finish, we can talk before I step out because my convoy, they're out waiting. I'm the babysitter today.
Okay.
Yeah, when I get to them, another job, full time. Okay, so Gertrude, I said if you have any concern, like the studying process, the document I sent you, I want you to go over it. It's just like a baseline information for you to understand the NCLEX whilst you are building on it. So, like I said, I also started at a point like that in Ghana. So I know it's really difficult. The exam setup in Ghana is different from here. So I don't want you to downplay it. That's why I sent you the document you got. The candidate performance report is what people who don't pass the exams will get. You only get that document when you don't pass. So if you pass, you won't get it. So for those of you learning to study, you want to know what they want, they ask direct. So that whilst you are studying, you are pinpointing those things on the candidate performance report so that you will not be lacking behind. Emilia, did you see the candidate performance report before?
After I went for the exams.
Oh, okay.
It was after.
Correct. You received that, right? So you have an idea of the areas. I had discussed it with the team before. I told them to try, there are topics on it. They bring the candidate performance report and they put topics on it. So for those topics they put, whilst you are doing this review, study those topics. And if you have questions on them, like right now, I know what Simone wants to tackle. She basically wants to go into pharmacology and the calculations. I have a whole setup with pharmacology that I'm still thinking. I don't think I can discuss it to finish here. I feel like it should be a video. I'm still working on which one to do. So a whole set of calculations with pharmacology, delegation and prioritization. And what's the other area? Let me write it down before I become. You said delegation and prioritization, right? Huh, Simone?
What was that?
The areas you want me to tackle, we have the medication calculation, that one I got it. So I'm still trying to figure out, maybe this week I should add those questions to it so that next week we'll finish the cardiovascular and we'll tackle that one. Or I will do delegation and prioritization and then the medication calculations. You need to know the formula. So medication calculations and then another one I want to talk about.
I think you should practice before you give it to us on the site, because we just had it on the site.
Okay.
So a little practice would work instead of testing again.
Oh, a little practice before you test, right? Okay, so I'm going to change the questions. I will. I also thought about.
Bring water. Go and bring the water so that I give you. Bring it, okay?
And I'm thinking about legal nursing, the legal aspect. So I'm also thinking of tackling that one. And yeah, okay.
Okay.
Yeah, I just got certified as a certified legal nurse. So I I just got my certification as a certified legal nurse consultant, and I'm grateful. It's been another hard journey for me. I've been working on it since January, working on my legal nursing course.
Congratulations.
Thank you. I just received my certificate last week, so I'm glad. So we'll tackle the legal aspect of nursing that the NCLEX will also test you on. Okay. So besides that, your assignment is to study about the temperature thing, because COVID has come to confuse everybody's mind. Everybody thinks temperature is now this one. When you walk in, I do this on your forehead and you go. So take notice of that. And pretty much that's it. So don't hesitate to contact me at any time. Gertrude, let me know your shortcomings. There's no shame. Okay.
Okay.
So have a good night. Huh? Any question? Okay. So we'll call it a night. Bye-bye. I'll see you Thursday. Same
Okay,
time.
I'll talk to you tomorrow. Thank you.
Yes, thank you. Okay, bye.
Bye.
Hmm?